Yeah, I should.
We are recording. We need to be on our best behavior, please. I don't think so.
Okay.
I don't think it's working right. I know what bad.
Is this it?
I
Oh,
apologize
that
for
was
the
Tina.
slides. We got my notes on the bottom. I don't know how you get rid of them. Let me show you the slides.
Oh, that's it.
All right, are we ready?
Yep, let's
All
go.
right. This is national guidelines for field triage of injured patients. I'm going to describe the update process, explain the new guidelines, maybe not in detail, and review local and regional use of the guidelines. Remember, follow your protocol and medical director guidance. The guidelines are used to achieve optimal patient outcomes to transport to most appropriate destination within the trauma system. For 3 decades, the guideline has been widely adopted by trauma systems in the United States to support decision-making by EMS clinicians in transport destination determination for injured patients. The goal has been to ensure that seriously injured patients are transported to the most appropriate trauma centers. The guideline helps to minimize variation in destination decisions. New research evidence since 2011 guideline. Oh, line update, because we have new research evidence since 2011. Reduced time and variation in making decisions and an opportunity to reduce under or over triage.
So when did TraumaCom start?
TraumaCom started in our TraumaCom, I'm not sure on that, but
Was it 11?
10 or 11.
So that's why.
but this is national.
National.
Yeah,
Okay.
this is all, this is
Okay.
national. This here was developed by the CDC, and there was another one.
The who?
CDC.
No, the who? The
World
World.
Health.
Oh, yeah. But who?
Yes.
It's like that video of the, did you hear about someone in here? Is it out?
All right, reduction in time to make a destination decision faster to call the trauma code. Opportunity to reduce over and under triage. This is, okay, the process of redoing and revamping the triage and trauma triage, it was a process that had taken 2 years. The expert panel included EMS clinicians, emergency physicians, trauma surgeons, nurses, EMS medical directors, EMS educators, EMS and trauma system administrators, system experts, a representative from stakeholder organizations. And if you look here, it says survey distributed tonight, 29 national organizations representing EMS and trauma with 3,958 responses. So this would be an example of your evidence-based research. Okay. All right, this is the old one. Does everybody recognize that? I don't even remember seeing this when I went to school.
No.
Okay.
Yes.
This is the old trauma triage from 2011. Okay.
No, I went to school way before then.
Huh?
I said I went to school way before then.
So now they've come up with a brand new one. And
Oh, yeah.
this is what the new one looks like.
Oh,
And if you see, instead of it going like an algorithm all the way down and trying to find, your patients, they are still using the 4 levels to assess vital signs and level of consciousness, assess anatomy of injury, assess mechanism of injury, and assess special patient or system considerations. They're still following that guideline, but they put it into a more simplified way, a more simplified flow for EMS, okay? And it gets to the transportation decision even sooner. Okay. The The guideline is intended to be read from left to right and top to bottom. And again, it's gonna follow the 4 steps that originally came out. Okay. That's really hard to say. All right, your red criteria. This is gonna cover your tier 1 and tier 2, okay? And anybody that falls under the red criteria, they are going to go to a level 1 or level 2 trauma center. Okay?
Say that again.
Any patient that falls under the red criteria,
Okay.
we're looking to send them to a 1 or 2 level trauma center.
That's pretty much our drop-down box in image trend, isn't it?
I don't want it. That's an image.
Pretty much.
It's like tagging, like triage for trauma. Yeah, but when you put like a
If
moderate
that's for your
or major-
Well, this
moderate
is
or
more
major
for-
trauma,
red, yellow, and green, is this not?
No,
It's
No.
this has nothing to do with the MCIs or disaster triage. This is
You-
just
you-
pretty
So
yeah, I
you're just
mean,
looking for
triage.
like a major or minor? That's what I'm thinking.
They are not, because it's national. Arkansas is the only one that uses a major and minor.
Oh, really?
it's gonna be, you're gonna see crossover though. You're gonna see
Okay.
where they,
You'll see, yeah. But anyways, so this red, like I said, the
other
criteria
words-
here,
Ours for red needs to be flown, pretty much, right?
here's what?
Needs to be flown. If it needs to
That's what I
go.
was just gonna say.
Okay,
I was gonna say, this red here, in our situation, we're gonna decide, do we need to fly them or not,
yeah, okay.
you know? If
Not a
our
lot of-
burn patient wouldn't have been able to be flown, where would we have taken them? Yeah,
Is Baxter level 3 or level 2?
3,
Oh, well, according to trauma con, we would have brought him here.
they're level 3.
3, okay.
Yeah.
I'm not sure if I wouldn't have drove Springfield with him ourselves. That's one of those.
Yeah.
I don't advocate for that very often.
I think you'd have got in trouble if you did.
And this just kind of
Stop
shows you the injury
pre-evaluation.
patterns that would be listed under the red.
Not want to call your doctor.
It was
Local doc.
Bozeman, I know what Bozeman was said.
Again, mental
Go on.
status and vital signs listed under the red that would tell you to send them to a level 1 or 2. Okay. Here's the yellow. Your yellows would go to your 3 and 4s. Okay? These yellow, the mechanism of injury, they do not have to be the highest level trauma center. So you can take them to Baxter, you can take them to wherever, bring them here. Oh, Lordy. We need to know our local and regional trauma resources, and we need to use them. There's Healthy Arkansas. If you want to go over what the red and the yellow, what the injuries are and stuff, that we can do that. But our local trauma centers, of course, we know Baxter Health, Fulton County Hospital as a level 4. All they do is stabilize and transfer. Baxter Regional is a level 3. Again, stabilize, transfer. White River, stabilize, transfer. Level 1 and 2 trauma centers, we know are further away. You got Memphis, Little Rock, Springfield, St. Louis, you know, and those, depending on weather, will depend whether they go air or we entertain.
What about Branson? What is Branson?
Mercy, they're level 2.
Yeah, so it's like, I'm
Did
not
you go to
sure.
Mercy?
Good.
I'm not sure.
Yeah, Pine Bluff too. I think they're 2.
And of course, we know who our air medical services are, and survival flight. With area back and survival flight, we know that dispatch rotates them. Unless we specifically, like we did the other night, the patient had a membership to area back. So we specifically asked for area back.
And then I kicked the patient's family out of the house.
And then we had to keep the patient family out of the house.
Okay, so I know that we have the insurance, through Airback, but what if they are not available? Like, for whatever reason, they're on another call, they can't, if they pick up survival flight, will airbag reimburse for the other company?
They
That's a good
used to, but now they won't.
Start saying, I don't think they do.
Okay.
Now, used to, they was, cause they had high hopes of, Damon joining the Air Med group. Damon told him he didn't need their Air Med group, he was doing fine on his own.
Okay, so let's look at the, let's look at these other.
Talking about these trauma centers and everything, New Year's Eve, Randy and I was listening to a MCI down in Little Rock, and they overloaded UAMS and Baptist and St. Vincent's within about 20 minutes.
Or was it?
They took,
Wow.
it was a wreck. They took 6 critical to UAMS, they took 5 critical to Baxter or Baptist, and they took 2 codes to St. Vincent's. Then they come back on the radio and said they had finally got a hold of somebody from the school, and they were transporting 31 green tags to Saline County.
Yeah, so I said that had to be a bus.
See, and regarding the
I
green,
guess, we did figure it out.
regarding the tags, the green, yellow, red, black, I think that is something that Mike would cover
Mhm.
next week or a couple weeks, okay? This is just your run-of-the-mill trauma, triage, injuries, and where you're gonna take them as far as, trauma centers. So your injury patterns in the red, as you can see, are penetrating injuries to head, neck, torso, and proximal extremities. Okay, so any penetrating, am I born in?
I'm sorry.
Skull deformity, suspected skull fracture. Suspected spinal injury with new motor or sensory loss. Chest wall instability, deformity, suspected flail chest, suspected pelvic fracture, suspected fracture of 2 or more proximal long bones. Crushed, degloved, mangled, or pulseless extremity, amputation, proximal to wrist or ankle, active bleeding requiring a tourniquet or wound packing with continuous pressure. Those are your injury patterns, your mechanism of injuries, okay? Mental status and vital signs. All patients, if they are unable to follow commands and have a motor GCS of less than 6, respiratory rate less than 10, and breaths per minute are more than 29. Respiratory distress or need for respiratory support, room air pulse oximetry is 90%, or I'm sorry, it's less than 90%. And then they break down the age groups, ages 0 to 9, if they have a systolic blood pressure less than 70. Ages 10 to 64, if they have a systolic blood pressure less than 90, and a greater heart rate. And yeah, okay, and then age 65. And again, heart rate and breaths per minute. These again will go to your level 1 and 2. No.
Now, on your, if you can get that small, if you want to. On your pulseless extremity,
Yes.
are you gonna try to reposition that before you red tag them, or are you just gonna dispose this?
So, that's something that they did not cover on the.
I didn't see it either, when you sent me that link, I was
Yeah.
looking for it too.
Would be protocol. wouldn't
Yeah,
it?
So if you
And
try to
like I said,
reposition-
follow your protocol.
yeah, you're allowed to try to reposition one time? Is that right?
I believe so.
That's what it used to be, but honestly, I haven't updated it.
Terry's supposed to be going over Baxter's.
And that's,
Yeah.
or in less severe pain. I mean, at some point, the patient's just like, no, don't.
Yeah,
No,
they're
I'll
gonna
try
be-
it, you know.
Yeah.
Now, if you looked at the graph prior to this word, our trauma, triage trauma, the flow chart.
Mhm.
You had to look at every single one of those little boxes to
Mhm.
determine what you were gonna do.
Yes,
next.
no, yeah.
All your algorithms, that's gonna take a lot longer than having to look at this list right now. You know what I'm saying?
Yeah.
Because you'll know immediately, okay, this is my patient. They gotta go to level 1, level 2, whether we take them, or they go by airplane, or not airplane, helicopter. So the yellow ones, then they can go to Baxter, White River, they can come here. Possibly Calico. Oh, no, because, you can't go to Calico, because they're not a level, they're not a trauma.
They're not affiliated.
With trauma either? They got rid of
No.
stroke and trauma?
They got rid of both of them.
Oh, what
see?
good are they?
They're basically just in the first aid station.
They have one nurse. What's that?
So are they independently owned?
No,
Oh, Lord, I don't.
Or are they White River?
they're not
No,
White River
they're,
either.
I don't
they're a
understand.
subsidiary of Baptist.
Are they a subsidiary?
Yeah.
Kind of like how
Heber.
Baxter came in, kind
Yeah.
of helped us.
Eber come in and took them,
And yes. I'm not saying I just get them.
and they can't get nobody. The doc they had hoped to get to run their ER told them no, because you got more for more money here. Came back out, right.
Oh.
Okay, again, the yellows, you're going to transport to your level 3 and 4 trauma centers. And your mechanism of injuries are going to be a high-risk auto crash, partial or complete ejection. And now again, you take that partial or complete ejection, and if it meets any of that red criteria, it's going to automatically be 1 or 2. Significant intrusion, including roof. Greater than 12 inches or greater than 18 inches. Greater than 12 inches occupant site or greater than 18 inches any site. Or there's a need for extrication for entrapped patient. Death in passenger compartment. Child age 0 to 9, unrestrained or in unsecured child safety seat. Vehicle telemetry data consists of severe injury. I've never seen a vehicle telemetry data.
That's the black box, isn't it?
Well, yeah, and who's the services that we occasionally get called because they
OnStar.
or OnStar, that type of organization, can say, hey, we detected a vehicle accident. They can give you that stuff.
I think one of the Ford cars is a Volvo. They have something similar.
Very possible.
You can't see.
I have no clue.
Okay, then that's okay. It's a Ford car.
A rider separated from transport vehicle with significant impact. Pedestrian, bicycle rider thrown, run over or with significant impact, fall from height greater than 10 feet for all ages. Low risk factors. And again, this is where EMS would use your judgment, corresponding with the red, where they're going to go. Lower level falls in younger children.
So they have changed mechanism of injury, fall from greater than 10 feet, all ages. Because it was 3 times your height, and then it went to 2 times, and now it's just 10
Now it's
foot.
greater than 10 feet.
Straight across.
Anticoagulant use, of course, you know, when you have an older patient who is on blood thinners,
Mhm.
you know, and there's a head injury, well, that's going to be considered a red, you know. Okay. Suspicion of child abuse, special high resource healthcare needs, pregnancy greater than 20 weeks, burns in conjunction with trauma. Now, we had that burn, it wasn't in conjunction with the trauma, but it was bad enough.
Well, technically it was, because we didn't know what caused the fall. He fell sometime.
That's right.
So we should have struck him. Oh no, we trauma banded him, didn't we? But we trauma banded him for the burn, and not for the fall.
You trauma band for the burn, yes, and not for the fall.
Okay.
So if you're gonna trauma band them for the burn, you have to give them another trauma band for the fall? No, you only have to trauma band for one of the injuries.
So whatever
Right.
trumps, and well, I'm assuming, yeah. But I mean, that would where your narrative would come in.
You know, I mean, which one was more life threatening? The burns.
Yeah.
You know, maybe if it caused, he fell.
I still think he stroked out.
Very possible. You know, like his daughter said, no alcohol, no drugs.
that she knows of. That she
Children should be triaged preferentially to pediatric capable centers. Of course, we only have one pediatric capable center, Children's Hospital in Little Rock. There are times where they do come here, but we end up flying them out to Children's. They go to Baxter, they end up flying them out to Children's.
We're gonna not here so much, but Mercy or Washington Regional in West Arkansas is seeing a lot more children.
Yeah, well, the children's put in a bill there.
Oh, so it's not Washington, it's children?
It's children's.
Okay.
And Le Bonheur, I keep hearing rumors that Le Bonheur's gonna put one in down around Jonesboro.
Oh,
They've been saying that for years.
So, but
Now,
they supposedly started looking at the ground out there beside NEA.
I have some other pages to show, but when I turn off my computer, I have to use it. So, but that's basically what I found regarding trauma triage. It seems to be simpler now than it was back then. But we have all been in this long enough. We know what needs to go to levels 1 and 2. We know what can go to levels 3 and 4. You know, when trauma said, when our trauma com said, take our burn patient to Salem, we knew right away that was the wrong place to take them, because there's nothing they're gonna be able to do with them.
yeah.
That's been my whole argument against TraumaCom from the beginning.
Yeah.
I love the grant money we get, but when we're sitting in camp and they say that patient needs to go to UAMS 2.5, 3 hours away.
Mhm.
Yeah.
you know,
And
See, and
they used to actually would tell you over the radio, yeah, we know they are only allowed who they can.
See,
Mhm.
okay, your patient was unstable.
Mhm.
And they told you to go that far.
Mhm.
Our patient was stable and would have made it
Mhm.
if we would have went that far.
Yeah, it's,
yeah,
It makes
But
no
they
little
have the
sense.
rules about who they can recommend and who they can't.
Yep.
And since there's no, level 1, 2 trauma up here available, they just route you to the first place, and that's possibly to the first place they can stabilize and then forward on. But again, you're the medic.
Yeah,
Maggie Gale cut that foot off down there at the hatchery that morning.
and from what I understand, our Arkansas Trauma Com gives recommendations.
Yeah.
Our recommendation would be,
Okay, so how many people take their recommendation seriously? Go, oh no, we need to take them the same as Trauma Com said so. Well, and then we get
I've
this-
talked to them on the phone, and the guy specifically just told me what I told you guys.
yeah.
Yeah, we can only recommend by what we have in front of us. We know you're gonna do what you need to
Well,
do.
used to, I know when we come in, the ER was asking, about the call and stuff. And so we told them that they suggested here. They said, well, can you report that? And I thought, oh yeah, because, used to an image trend, it would say, did TraumaCom recommend? Did you go by recommendations? Why and why not? It didn't pop up
Mhm.
Oh,
on this
okay.
on this call. So, and it used to, they would ding you if you didn't go to where they wanted to go. And I guess maybe they got their hands slapped too.
Well, we're just in a no man's land up there.
Yeah.
Yes. So we kind of have to,
I thought he wanted to talk to me.
he knows where to find
I know, but
you. So he can,
like,
it was
he needs to
critical
wait.
too. So.
Yeah.
If it was too bad, you'd have
So
already been in
who
the office.
was
That's
the
true.
cut foot?
Maggie Gale up there at the hatchery. She was feeding fish. And she jumped up on the wall to go across. And she hit a piece of moss and her leg went down into the aerator and it took the foot off. When Randy and I got there, he's like, go ahead and call them, because it's against my better judgment. We called them. We recommend this patient come to UAMS by air. Well, be advised, it's bringing cats and dogs out here, and it's a 3-hour trip for us. We're going to West Point.
Alright, that's it. We're still recording.
Good job, bro.
I wish there was more to cover. It seemed like a lot more when I was going through the information.
How'd it go?
It went well.
Okay.
We're done
Trying
for
to hurry and get back.
today.
Trying to hurry and get back.
I'm
think we're gonna have
basically
an
gonna jump
emergency.
on where she left off tomorrow and go a little further with it.